I love the talking heads that you have in the background there. That reminds me of some really good music.
Yeah, I do like them a lot. I've got a couple back there. I'll have to share them with you sometime. So yeah, this is a. Is everybody ready to get started?
Yeah, let's go.
Jump right in. So this is a 25-year-old female presenting with dark urine and pruritus. And we'll let Natasha, you want to take the first stab? Tell us what your thoughts are.
Sure. I'm a little biased because I know our consultant is a hepatologist, but just with dark urine and pruritus, thinking what's causing the dark urine? Usually when I think of those two things together, I think is there bilirubin or urobilinogen in the urine. So I'm automatically thinking like a liver, gallbladder kind of pathology. I'd want to know how long it's been going on. Like to characterize the pruritus, and then like baseline health problems, medications, things like that.
Perfect. Yeah, so I can give you a little bit more of that history. It's been going on for about a month. It started off with some nausea and some vomiting, and the dark urine started probably about a week and a half ago. And it's just kind of the itching is all over.
Is she presenting to you in clinic or is she in the ER?
She's coming to the ER. Any other thoughts, Drew? What do you think?
So the one thing that I would ask actually is like, has she been in any sort of stressful situations? This is a young adult who's presenting with dark urine pruritus, which basically screams at me hyperbilirubinemia, likely direct hyperbilirubinemia. And one of the things I was thinking of was Gilbert syndrome, which is, I would say, a bit milder than this, but presumably she could be stressed out enough that this could happen.
Yeah, so no recent stressful events that she notes.
Oh yeah, and the other thing, is she pregnant?
I think she's aware of, but she is sexually active with one male partner, the same male partner for the last 3 years. Anything else you want to know, either Drew or Natasha?
Has anything changed over like the past month or so? Any changes in diet? Any new medications?
Great. Yeah, no changes in medication or diet.
Is she having any pain?
Oh, great question. No abdominal pain.
And how much is she throwing up?
Probably about once a day.
Okay, is it associated with eating or anything like that?
Not associated with eating. First thing in the morning when she wakes up.
And any fatigue or decreased activity tolerance?
Yeah, just generalized fatigue for about the same time, about a month.
Has she noticed any yellowing of her skin, of her eyes, of the inside of her mouth?
Yeah, so she's actually got some Ceruloplasmin.
Any changes in stool color or character or frequency?
Not that she's noticed. Great question.
And I know she has dark urine, but any like pain when she urinates, burning, retention?
Nope, nothing like that.
Okay, and any other systemic symptoms like fevers, chills? I know we already talked about fatigue.
No fevers or chills.
Okay, what about anorexia, weight loss?
Nothing like that.
Okay.
Or early satiety as another surrogate event. And the other question that I would have, just in terms of like past history, and this is my peds brain yelling at me, what has her vaccine history been like, specifically her hepatitis A and B vaccines, and has she been screened for Hep C?
She's up to date on all vaccines, and no in the past.
Just making a note there, because Clinical Pearl, anyone aged 18 to 75 is now recommended to have a one-time Hep C screening.
Yeah, perfect. So what are y'all thinking as far as a differential right now? You're asking a lot of great questions, mostly focusing on the review systems, trying to hone in on where our main concern is. What do you think could be going on?
So usually when I think of an elevated bilirubin, kind of the first thing I think of is she having some kind of obstruction? I would expect her to have pain or like symptoms more associated with food. If that were the case, it could also be like something genetic. I think Drew kind of alluded to that already. Usually I think the conjugated ones, conjugated hyperbilirubinemia. I always get them backwards. I thought Gilbert and Krigler and Najjar are those unconjugated, and then Dubin, Johnson, and Roeder are conjugated. I always have to look it up.
I'm right there with you. I usually have to look it up as well, but I know Gilbert's is unconjugated, Dubin Johnson conjugated, but I'm not sure that's the one you mentioned in the middle.
Okay, I know that Dubin, Johnson, and Roeders go together, and then Gilbert and Krigler and Najjar. So that's a good process of elimination right there.
Dr. Gray, which one?
You're correct. The Gilbert goes with Krigler. I can't even say it. I have to look it up too, to be honest. So don't feel bad that nobody knows that. But that's also like, in infancy, and so we're kind of out of the age range for that. But I love listening to you guys ask questions, because I can sort of hear the differential in your head, which I think is so good. So I mean, when you're asking about pain, I think in your head, you're probably thinking about things like gallstones. Does she have cholelithiasis, biliary obstruction? So I love that question. Certainly viral hepatitis can do this. So I like that you're asking about, fevers and chills, certainly hepatitis A or acute hepatitis A or acute hepatitis B. You can come with nausea, vomiting, not feeling well, jaundice, all of those things. So those are really important questions to ask. You asked about weight loss, night sweats. We certainly can see lymphoma present a cholestatic hepatitis, like we saw with the first liver case we did in the series. Also cholangiocarcinoma can cause jaundice. So you guys are asking every single question that I would have wanted to know too. So that was awesome. Drugs, toxins, medications, herbal supplements, all of those kind of things can cause jaundice. So I like that you were asking about, is she taking anything new, antibiotics, those kind of things. Pregnancy, of course, we think about things like intrahepatic cholestasis of pregnancy. So I was glad that you asked about her pregnancy status, and that comes with a ton of itching. So that was a really, really important part of the differential. Let's see what else. There's also, genetic things are super important. So things like progressive familial intrahepatic cholestasis, or PFIC, can affect patients kind of around this age range. Autoimmune hepatitis would be another thing on the differential if she has any personal history or family history of autoimmune diseases. So that's kind of where my mind would start. And I think you asked, all the right questions. Without having labs, you could have asked as much as you could, maybe just except for the autoimmune history. But I think you guys nailed it.
And I think just to add on to the autoimmune history, like PBC, PSC as well. To sort of add on to the case, that we had yesterday evening that we were discussing earlier, any history of like sore throat or anything like that? Unusual, but
Actually, the fact that you said that, we probably had 3 cases of jaundice and high liver tests in the last 6 months from syphilis. So I now include that on my differential. Just going along with infectious etiologies. But.
Oh yeah, and IgG4.
Yep. Yeah, that would fit in sort of your autoimmune category. So IgG4 disease. I think we talked about maybe on the first session, the PBC and PSC, typically by the time those cause jaundice, it's pretty advanced. So you would think if that was the case that she would have some other signs of cirrhosis or advanced liver disease, but we haven't had our physical exam yet, so we don't know those answers.
Great. And it sounds like you guys are wanting maybe some labs next to kind of direct more questioning and exam. I will give you a little bit more, one additional point on the history. Say that when she got her hair done about 2 months ago, that they a lymph node on the back of her neck that she said is no longer there. It resolved after a month. And some labs, we'll just show the liver test. Go from there. So you have an AST of 1,000, ALT of 877, of 189, T-bill of 19 with a direct of 17. Drew, I'll let you take this one first. Thoughts?
A bit disoriented since it's not in the usual way that I would see it, but I would turn it 90 degrees. So one T-Billy, so this is a direct hyperbilirubinemia with a little bit of indirect Billy. Alk phos are pretty high. AST and ALT of, oh no, this is bad. I mean, at this point, I'm thinking of things like alcohol or even like Tylenol use, but like with the AST, ALT, but we're focusing on the Billy here. And
yeah, really for alcoholic hepatitis, you shouldn't see aminotransferases above really like 250. 250 would be pretty high for alcohol. So I'm going to take that off your differential for you.
Okay. Oh yeah. Gamma transferase. Did you get that as well?
Lindsay's making here a super high liver test. There is a very specific differential for extremely high AST and ALT. So you got one of them with Tylenol. Natasha, do you know?
Yeah, so usually the viral hepatitides are always up there. Some drug-induced liver injury also. Trying to think what else. You already said Tylenol.
Can shock liver cause it?
Yes, actually it can.
One other big one that's missing. Autoimmune hepatitis.
Yeah, autoimmune hepatitis.
5-year-old, this could be a very classic autoimmune situation. But yeah, any ischemic injury can do that. So shock, Budd-Chiari would also kind of go in that category as well. Yeah, you can also put Wilson's on the differential. Certainly not common, but you can do this.
I mean, this is a 25-year-old. We should, any genetic diseases should be on the table.
That's good.
Okay, any other tests you guys want or any other questions you want to ask?
I think I'd want to get a CBC as well. I know this is not necessarily a a indirect Billy that we could say it's hemolysis, but I just want to see if like there's issues with hemolysis that are making the thing worse.
That's perfect. Yeah. So her white count is 9. Platelets are 3.
Could we get a BMP as well?
I'll tell you that it's normal.
Okay, that's perfect.
In the chat, somebody was asking about rhabdo. You can see that you can see really high liver tests related to rhabdo. Typically, the AST will be quite a bit higher than the ALT.
Could we also get an INR if you have one?
Yeah, great question. Why are you asking?
Just to see if like liver function is preserved, because her platelets are elevated or normal, so that's reassuring. And okay, so the INR is also normal. So it sounds like whatever happened is probably more acute. And Dr. Gray was talking about maybe like we're worried about if it were like PSC or PBC, you should already see signs of cirrhosis. I guess we didn't technically get the full physical exam, but at least from the labs, it seems less likely.
Yeah.
Next up, I would probably want a right upper quadrant ultrasound. I don't know about everyone else.
I don't want a pregnancy test.
Yeah, exactly. Although then again, I think you could probably do both at the same time. The other thing that I wanted to mention as well is that for her, the other clue that we can get for this sort of being an acute process that's not affecting like liver function is that her albumin is decently high enough that at least I wouldn't think that her synthetic function would be affected.
Yeah, I think that's a super important point. So certainly if we're thinking about someone who has acute liver failure, then we're looking at coagulopathy and encephalopathy. But she does have, her bilirubin jaundice is a sign of liver synthetic dysfunction. But thankfully, like you said, albumin and INR are good right now. So it does not look like this patient has acute liver failure, just very significant liver injury.
Yeah. Oh, and one more history question that I wanted to ask. How has her sleep been? Has she been like sleeping during the day and active at night, or has she been waking up later or getting to sleep earlier?
Nothing like that. She's just been sleeping a lot more during the day because she's just been really fatigued.
Okay. The reason I asked is because that's the first sign of hepatic encephalopathy, is sleep-wake cycle inversion.
Yeah, that's great.
And her urine pregnancy test was negative.
Okay, very good.
Can I ask a question? I'm spotting the chat here, and there's a question about when do you order an ammonia, and is ammonia ever useful to you in a patient like this?
I guess our clinical exam would be extremely helpful. If this patient is awake and alert, then no, I don't think that ammonia has any role. I think there's a couple of places where ammonia can be really helpful. One is in a patient who's obtunded and you're not really sure what's going on and whether or not it could be related to the liver. I think ammonia can be helpful in that setting, although you have to realize ammonia can be elevated from other things besides just the liver. And then the other is in acute liver failure, the ammonia level does have prognostic value. So ammonia levels, especially higher than 200, are more at risk for herniation, brainstem herniation and things like that. So those are really the only two indications. But in someone who is awake and alert and has no signs or symptoms, definitely not helpful. May we have a physical exam, please?
Okay, so she's afebrile. Heart rate's 58. Respiratory rate's 15. Blood pressure is 119/66. Statin 98% on room air. She's ANO times 4. No distress. She has scleral icterus. No lymphadenopathy. Her abdomen soft, non-tender. Yes, she has some hepatomegaly and no lower extremity swelling. No rashes or anything like that.
Any splenomegaly at all?
No.
So what do you guys think about when you see the hepatomegaly? Does that help or change your differential at all?
I think it might make an obstructive process a little bit more likely, but I mean, at this point, it doesn't really change anything that we already knew, because viral hepatitis can cause hepatomegaly. Autoimmune hepatitis can cause hepatomegaly. Wilson disease can cause hepatomegaly. I think it might put drugs or like shock liver or ischemia down the list, unless it's like a congestive process. But a congestive process would affect liver synthetic function, and that's not happening here.
Yeah.
Meagan?
How big is the liver, Lindsay?
Oh yeah, right.
You can barely feel it, like right under, it's kind of crossing over the midlines. You can feel it more crossing over this way than down. But you can definitely feel it in the epigastric. She's a small person, and you can definitely feel it like in the epigastric area.
So Megan, this comes up a lot, and my initial mentor and chairman was Hal Fallon, who was one of the first people who studied autoimmune hepatitis and steroids, and he went to a lot of detail on how you measure liver size. And I'm interested, as a hepatologist, what we should be thinking about when we're talking about hepatomegaly versus not hepatomegaly by physical exam.
Yeah, I mean, if the liver is normal in size, you really should not be able to palpate the edge of the liver. And so, you know, liver, of course, sits underneath your right ribs, and you should be able to push in there and really you shouldn't feel the edge. So then we kind of think about how big is the liver in terms of how many finger breaths below the lowest rib is. And so, I mean, sometimes patients have massive hepatomegaly, especially, you know, Budd-Chiari is something you think about, massive tender hepatomegaly, alcoholic hepatitis, massive hepatomegaly, lymphoma, you know, these are kind of things, depending on how significant it is, that can cause really significant liver swelling. You're right. I mean, anything that causes inflammation in the liver, so autoimmune hepatitis, viruses, you know, these things certainly can cause it to be slightly enlarged. But when you're talking about massive hepatomegaly, there's not a whole lot of things that do that.
And that's the reason I asked about splenomegaly too, is because lymphoma's on the differential.
Absolutely. Yeah, more often than not, if you just have a cholestatic drug injury, the liver will be normal in size, for whatever that's worth. So I think things that we don't have labs back yet for would be certainly our viral panel, autoimmune hepatitis. Those would still be things on our differential that we haven't assessed yet.
So your hepatitis B, HCV, HAV, HEV, we sent that out to, are all negative. Were there any other viral viruses you guys wanted to check? Drew, Natasha, Dr. Gray?
I think EBV and CMV.
Okay. Also negative. Great. And Dr. Gray, you mentioned something else other than virus. I missed that.
Autoimmune. Okay.
Negative as well.
And then we had also talked about Wilson's. Do we have a Ceruloplasmin or?
It was 1 point elevated. So we just went ahead and got a 24-hour urine cortisol as well. So that was negative. Or urine copper, I said cortisol. And the ceruloplasmin, I can't remember the upper limit of normal. I think it was 34 or so, but it was barely elevated. And so we just went ahead and got it, and that was negative.
Okay.
Why am I now thinking about like an iron panel? I don't know why I'm thinking of hemochromatosis for some reason, but I guess given the fact that we're considering Wilson's disease, but I don't know that hemochromatosis can cause a direct hyperbilirubinemia.
No, this would be, yeah, I've never seen hemochromatosis do this. It's really just a chronic chronic liver disease with chronic mildly elevated liver tests, it really doesn't cause this acute syndrome.
And also, could we get a little bit of a discussion on ceruloplasmin? Dr. Comfort put in the chat that we use it as a measure of like an acute phase reactant, but apparently there's questions about its utility as a test in Wilson's.
Yeah, so, ceruloplasmin can be a little bit tricky. So, of course, for patients with Wilson's, we expect them to have a low ceruloplasmin, but there's lots of other conditions that can also cause that. So certainly hyperbilirubinemia is a common cause of low ceruloplasmin levels. I'm actually kind of surprised this patient had a normal one. And then, as you were mentioning, ceruloplasmin can be an acute phase reactant. So if the ceruloplasmin is normal, that doesn't necessarily rule out that the patient could still have Wilson's. So that's why I'm sure that's why you guys went ahead and sent off that 24-hour copper, which I also would have done. So Mario was saying that there are some other markers for autoimmune hepatitis, which is true. So he's mentioning some of the less common antibodies, which we had in the case that we did on the second episode. Sometimes what can be really helpful, and those antibodies that you're mentioning typically take a few weeks to come, or at least a week or two to come back. So what can be more helpful in the short term is a total IgG. So if the IgG is normal, it's pretty unlikely that the patient has autoimmune hepatitis, and that's going to come back much quicker than some of these send out antibodies.
Great. And yeah, the total IgG was normal, as was the anti-liver kidney, I think, antibody. Is that one of the ones he had mentioned in the chat? Okay, that one was negative. We didn't check any others.
I think we're probably getting close to getting some imaging.
Okay. Perfect.
and Uncle Bob is yelling HSV in the chat.
HSV is always, if you think of it, you should check it for sure. The thing I would say about HSV is that typically you don't get this high of a bilirubin. The classic HSV presentation is mildly elevated bilirubin, maybe like 2 to 3, and then very high liver enzymes. So I think it's unlikely, but certainly we can check it.
HSV was also negative.
How about syphilis? We did bring that up as an option.
So the RPR was positive.
That does not say anything. I need a treponemal to confirm.
So the treponemal antibody was positive.
Ooh.
And
FTA-ABS?
and the RPR was a 1 to 128 dilution.
You guys know more about this than me. You should explain to me what all this means.
So essentially she had syphilitic hepatitis, and you got to that really quickly, and you actually mentioned it in the very beginning. Part that was really interesting in this case is we didn't get to this as quickly because the time at which the labs come back and how sick she was and how high her levels were. So the RPR didn't come back for a while. So she had a ultrasound that was done that didn't really show much, MRCP that didn't really show a lot either. And then she ended up having a biopsy before a lot of these labs came back. And it was suggestive of what the team thought was autoimmune hepatitis. And so she was actually sent home on steroids for a couple days. And then her labs came back and the RPR, treponemal antibody, came back positive. So we called her, asked her to stop the steroids, asked her to come back in and get some penicillin. And her liver studies resolved within a couple weeks.
I think I saw this patient in the clinic with Sue John.
Oh, yeah.
But yeah, this is the first case I've seen of this. And to be honest, syphilis isn't something that, like, if we were doing this a year ago, I would have not even put syphilis on the differential. I just don't think about it that often. But yeah, I mean, her biopsy had changes that were concerning for autoimmune hepatitis. And I didn't think syphilis could do something this severe. So we're like, well, we're just going to treat her with steroids. And ID was like, no, she doesn't need steroids. Stop all that stuff. So I remember her. That was an incredibly interesting case. But yeah, we read a little bit more about it. It's exactly what ID told us. You know, you just treat them with penicillin, and about 4 weeks later, everything's completely back to normal. They don't need steroids. They don't need anything else. And the really great case.
Awesome. And we did actually ask them to go back and review in PATH, the PATH report, and see if they could stain for spirochetes. And they tried to stain for spirochetes and it was negative. But when I was reading about it, it's actually really, really difficult, even in somebody with syphilitic hepatitis, to get the spirochetes on a PATH slide and actually identify it that way. So really the best test for this is either the RPR and treponema antibody, because you just increase your likelihood of the diagnosis and saves the patient from having an otherwise invasive procedure.
Yeah. Yeah,
Wait, they didn't get to see those tumbling little corkscrews on a dark field?
I wonder if that has anything to do with how we like put the biopsy in formalin and how it's processed. I wonder if that decreases the yield. I don't know.
I'm not sure. But great job, everybody. Great job, Drew. Great job, Natasha. Thank you so much, Dr. Gray.
Yeah, you guys should definitely be looking out for this. I think we've had 3 cases almost identical to this within a short time period. So for whatever reason, it is more common, kind of like Hep A's been going around. But
have your other cases presented similarly with this Billy?
Yeah, there was one patient was a young guy, I think on the neurosurgical service, and the other was on trauma surgery. They were both young men, and they were there for some surgical related issue, but were jaundiced and had very high liver tests. And of course, we were thinking about trauma and ischemia and all these kind of things. And because of this case, we were like, well, you might as well just go ahead and check an RPR. And then they both ended up having, but yeah, very similar, same jaundice, same extremely high liver test, so almost identical. But yeah, we probably would have missed it if it hadn't been that this case was in our minds.
And I know that you can see an abnormally low ALK phos in Wilson's. Were you also seeing that's one thing that kind of stood out to me in these labs for this patient, is just in comparison to the Billy and the AST, ALT being so high. Were you seeing that in your other cases of syphilitic hepatitis? That
the ALK phos was slightly high?
Oh, it's just it was normal, essentially 189.
To be honest, I don't remember that. I mean, I don't think the ALK phos was extremely high. I think it was probably close to normal. Yeah, but that's correct. Yeah, zinc and copper kind of compete for absorption. So in Wilson's, you don't absorb as much zinc, and then zinc is required to make ALK phos. And so you have low ALK phos levels in Wilson's.
Since this is unRemarkable labs, there are 2 other ways we can check on whether an ALK phos is coming from the biliary tract. There's the GGT. I'm assuming the GGT wouldn't help us here, because if the AST and ALT are elevated, the GGT is going to be elevated. And then there is, for some reason, a test we never use anymore, the 5' nucleotidase. Have you ever used those? And why were we using it so much back in the 70s and 80s and not using it now?
I don't know if that's just lab preference. Actually, where I did my fellowship, we very commonly checked the 5' nucleotidase. So I don't, maybe just it's a send out lab and takes a little bit longer to come back, but I find those tests to be the most helpful when it's a case of isolated ALK phos elevation. So everything else is normal. Your bilirubin, AST, ALT are normal, and you just have isolated ALK phos. And then in that case, of course, if your GGT or 5' nucleotidase are high, then you do kind of try to chase down a liver etiology for that, PBC or sarcoid or something like that. But of course, if the GGT or 5' nucleotidase come back normal, then you're thinking more bone turnover or kidney disease or something like that.
So we usually end with reflections. So I'm taking over, Lindsay, because I like to. So I think that what the order will be Dhruv, Natasha, Lindsay, and then Megan. Reflections on lessons learned from this case and things that we ought to try to remember. So MedPeds, go ahead.
One, this case is one that certainly will get us closer to Osler. Because again, he who knows syphilis, everything. Two, and I guess sort of on that point, we had a discussion yesterday on or actually at Student VMR on Sunday, about syphilis testing in the United States. And I was wondering, actually, Lindsay, did you guys get the treponemal antibody first? Like, did you do the reverse algorithm or did you do the traditional?
I don't remember. I remember looking in the chart and both of them being there. So I'm not sure which came back first. It was in follow-up and we were rechecking her labs after she had already left.
Ah, okay. Because here at MCV we do a reverse algorithm. So we do the treponemal antibody ELISA first, then either RPR or VDRL, and then FTA ABS to confirm. The other thing is that just reflections on differentials for direct hyperbilirubinemia, AST, ALT greater than 1,000, which is very few, and massive hepatomegaly, which is also very limited amount of causes.
Great, Natasha.
Yeah, so I definitely wasn't thinking syphilis at all, but I'll have to add that to my differential. Actually, just a couple of weeks ago, before I'm on Tinsley now, but I was on the VA, I admitted someone, and I don't think, as far as I remember, we actually found a great answer. And now looking back, we did get a syphilis on him. So that's definitely the biggest one. And then I guess I didn't know which thing specifically caused massive hepatomegaly. And then takeaway, if it's like a young female of childbearing age, always get a pregnancy test.
Perfect.
Lindsay, it was your patient, but I'm sure you have reflections after this.
Yeah, definitely. Number one, I can't stump Dr. Gray yet, but I'm determined I'll get she's smart. Other things is, just having the opportunity to take care of this patient in the hospital. Immediately when she came in, there were some tests that she had that were just like a little off. It didn't make sense. It didn't fit with the picture. So I was actually texting Sujan, the hepatology fellow, asking him about it. Like, can you get her in clinic? Can you see her in clinic? Do you think she needs a consult right now? And so we were kind of talking back and forth kind of about how to best manage, and glad we were able to get him into his clinic where he got to see Dr. Gray, or she got to see Dr. Gray. It's hard to tell, when you should go for that, invasive biopsy test to try to arrive at a diagnosis versus wait for some of these labs to come back. She was somewhat improving, but she actually left the hospital and came back worse. And that's what prompted the biopsy. And so I think in that setting, just working closely with your hepatologist to figure out what's best and what labs are missing. And don't forget about checking the syphilis as well, having that on the differential. We did not have that on the differential the first time when she came in, but on the second time we did.
Yeah, I was curious who was the one who came up with ordering syphilis. Was it, I wasn't on service at the time. Was it hepatology, or you guys thought of it, or?
So our attending was ID.
Oh, beautiful. Okay. Now I was wondering how ID got involved so quickly, but that makes more sense. You guys are lucky to get around with ID. They just think of so many things that we otherwise wouldn't think of.
That was a great learning point for me.
So Megan, why don't you give us the final thoughts on everything we discussed today?
Yeah, I mean, I just think that it's always important just to tailor the history questions you're asking to your differential. So, you know, whenever you're asking patients about their history, kind of be thinking in your head, like, well, I think it could be viral, therefore let me ask about this. I think it could be a stone, so let me ask about this. And so, you know, I think it's just really helpful as you ask patients questions to be sort of actively thinking about what that differential is in your head. I thought you guys did an awesome job with this, and certainly I now have syphilis on my differential after seeing this particular patient. But I guess the only other thing is, you know, always try to do the least invasive testing first. Obviously this patient got a lot of testing, but sometimes you can't help when the labs come back. So sometimes there's not much you can do about it, but.
And just to remind everybody, so this is my observation. We had a history of someone who's monogamous for 3 years, but just because you're monogamous doesn't mean your partner's monogamous.
That's a great point. Yep.
Unfortunately, for disease purposes. Thank you all so much. Great job, Lindsay and Megan. As we expected, I advertised for y'all on Twitter because I knew this would be just tremendous.